Very good morning to all of you. Going to talk on these topics, various terminologies related to UTIs, asymptomatic bacteriuria, UTI proper in pregnancy, and why UTIs are common in pregnancy, bit of microbiology and the treatment, and a little bit about sterile pyuria. So we'll straight away go to the terms. So the most important thing is to understand the various terms related to the urinary tract infections. So what is UTI or urinary tract infection? So you have to have symptoms of urinary tract infection. So there is lower UTI and as well as the upper UTI. Lower UTI is what we call as cystitis, the infection of the bladder. So you will get low abdominal discomfort, dysuria, and urgency to pass urine. And if you have an upper urinary tract infection, you will have fever, rigors, and the loin pain, that kind of classic symptom. So you have to have symptoms. And in the urine full report, you will see pyuria. And in the urine culture, you will see a bacterial growth. So to say it's a positive urine culture, usually the cutoff is more than 10 to the power 5 colony forming units in a milliliter of a clean catch urinary sample. But if you take a sample from a urinary catheter, so the colony count we need to diagnose the UTI is a little bit less. It's 10 to the power 3. So that's a bit important. Sometimes we don't recognize that fact. So you have to have all three, the symptoms, pyuria, and positive urinary culture. So then what is asymptomatic bacteriuria, which is a very important concept, especially with regard to the pregnancy. We'll discuss it about why it is important. So the asymptomatic bacteria, as the name implies, you don't have symptoms, but you have the bacteriuria, so your urine culture will be positive and there will be a growth. People with asymptomatic bacteriuria can have pyuria, or sometimes they might not have pyuria, so you have to keep that in the mind. And so then you have the sample contamination. Sometimes when you collect the sample, you can get it contaminated by the vaginal flora or the perineal flora. So here you don't have symptoms. You don't have pyuria, but you have a positive urinary culture. So especially when we talk about a sample contamination, usually you have more than 3 organisms, so what we call as heavy mixed growth. So but you can get a UTI with 2 organisms. Sometimes you can have urinary cultures positive for 2 organisms. So but when it comes to a contamination, usually you will have 3 or more, and then the the microbiologists will not give the 3 or more organisms. They will tell it as a heavy mixed growth, right? So and also when it is getting contaminated, you can get more epithelial cells in the UFR, right? So squamous cells, it comes as epithelial cells. There is a rough kind of cutoff. If you have more than 20 epithelial cells, that might indicate a contamination. That's a rough guide, but just keep that in the mind. And also this concept called sterile pyuria is also very important, not only during pregnancy but in the other adulthood diseases as well. So sterile pyuria is, sterile means you don't have a bacterial growth in the urine culture. So culture will be negative, but you will have pyuria, right? There will be pus cells in the urine. You can have symptoms, or you might not have symptoms, right? So it's a bit confusing, but at the beginning, I would like to stress these 4 terms, and then we will discuss one by one and the importance with regard to the pregnancy. So asymptomatic bacteria, as I said, as the previous speaker also stated, it's a very important concept. So the problem of asymptomatic bacteria is it's asymptomatic and it can cause trouble in the pregnancy. So it's quite common. It occurs about 2 to 7% of pregnant women, which is quite a large number. Unless you screen them, you don't know whether they have asymptomatic bacteriuria. And it typically occurs mostly in the first trimester. So, and about 75% of the cases we diagnose in first trimester, and they can get new onset bacteriuria in the second and third trimester as well, which is about 25%. And so is asymptomatic bacteria is more common in pregnant women than healthy women, non-pregnant women? Not really. The incidence is more or less the similar in non-pregnant women as well as pregnant women. But the problem is you can get recurrent asymptomatic bacteriuria in pregnant women, which is going to be a problem. And also compared to the non-pregnant women, the problems you can get from asymptomatic bacteria is more in pregnant women, of course, because you have mother as well as fetus. So you can get the problems to the mother as well as the fetus, which we are going to discuss in this slide. So how do you get asymptomatic bacteriuria? There are risk factors. People who have had urinary tract infections in the past, even in the non-pregnant time, they are at higher risk of getting a asymptomatic bacteria during the pregnancy. And of course, if patient is having already diabetic, and also people from lower socioeconomic status, that is related to the hygiene, and so you can get asymptomatic bacteriuria commonly. So the importance is, without treatment, about 1/3 of pregnant women with asymptomatic bacteriuria can develop a symptomatic UTI, including pyelonephritis. So that's why we need to diagnose this early and treat it accordingly to prevent that problem. And on the other hand, if you eradicate asymptomatic bacteria, you can risk of getting a UTI is reduced in a huge number, like 70 to 80%, right, which is very important. So what are the other problems? Is it only related to getting a UTI in pregnancy? Not really. Asymptomatic bacteriuria is known to be associated with the pregnancy complications such as preterm birth, low birth weight, and also perinatal mortality. And there are a lot of studies which have shown this, the importance of treating and recognizing bacteriuria early, right? And there is a case control study which is involving 15,000 pregnant women, and which has shown an increased risk of preeclampsia as well related to bacteria. Now you can understand asymptomatic bacteriuria, it's being asymptomatic, hard to, it's unless you screen, you don't diagnose it, but it can cause grave problems to both fetus and the mother, and and it is going beyond the urinary tract. So that's the importance, right? So then, having discussed about asymptomatic bacteriuria, we are going to discuss about UTI proper in pregnancy. So urinary tract infections, as I said earlier, acute cystitis is the lower UTI, the pyelonephritis is the upper UTI, which is common. About 1 to 2% of incidence of cystitis, and about 0.5 to 2% of pyelonephritis incidence is recorded in pregnancy. And the problem of acute cystitis is it can always cause ascending infection and lead into acute pyelonephritis, maybe up to about 50% of the cases, right? So all these numbers are related to the pregnancy, right? So pyelonephritis, out of the two, the more problematic one, which is more commonly occur in the second and third trimester, compared to the cystitis, which is more common in the first trimester. So cystitis, unlike asymptomatic bacteriuria, is not really shown to be associated with a lot of pregnancy complications. So why is that? Like, asymptomatic bacteriuria can cause all sort of problems, but UTI is not associated with much problems. The reason is UTI is symptomatic, and we diagnose it and we treat it. But asymptomatic bacteriuria, we don't diagnose, and slowly the bacteria can reach the upper urinary tract and cause trouble. So that's the reason. And however, the pyelonephritis, as you will know, it's a systemic infection. It can cause a lot of trouble, septic shock, increased mortality, and also it can associate with adverse pregnancy outcomes such as preterm birth. So Dr. Banagala discussed about few things related to the physiology as why the UTIs are common in pregnancy. Commonly it is due to the ascending colonization. Whatever the bacteria in the perineum, on the vaginal flora, it can easily ascend and settle in the bladder due to various reasons. So one is, progesterone, which is being secreted throughout the pregnancy, which causes smooth muscle relaxation, So it relaxes the bladder sphincter, it relaxes the ureteric smooth muscles. So usually the urinary tract is resistant, it's usually sterile, but in pregnant women, because of these physiological changes, the perineal flora can easily ascend and settle in the bladder epithelium without causing much trouble, without causing much symptoms, right? And also you have a gravid uterus, it can press on the bladder, causing urinary stasis. And also, as previous speaker mentioned, you have increased blood flow. There is a lot of urine always filtering. Because of the increased GFR, there is a lot of urine coming through the bladder and the urinary tract. So pregnant women has to go to the loo each and every time. So it will be like, contaminated. Perineal area will be, there will be urine because of the frequency of the urination. So it can easily help this bacteria to ascend into the bladder and settle there. Glycosuria and the increased secretion of amino acids, which is a non-physiological change in the pregnancy, it can act as a culture medium to these bacteria and it can grow easily. So these are the reasons why UTIs are common in pregnancy. So a bit of microbiology. The E. coli, the Escherichia coli is the commonest bacterium, as we all know. It is the commonest bacterium which causes UTI in the adulthood as well. It is the commonest cause. About 70% of both asymptomatic bacteriuria as well as the urinary tract infection is due to E. coli. But there are other pathogens, especially the group B streptococcus, which is an important pathogen, not only because it causes urinary tract infection, but it can cause problems in the neonatal pneumonia, neonatal sepsis. So it's very important pathogen to identify early and treat it. The other gram-negative bacilli like Klebsiella, Enterobacter, Proteus, they are usually common. Also Staphylococcus saprophyticus is a gram-positive cocci, is a staphylococcus, which is also can cause quite severe urinary tract infections in pregnant women. So these are the common organisms. So if the urine culture is showing multiple organisms, so you have to suspect whether there is a contamination, right? So especially when it is growing the perineal flora like lactobacillus, and also this bacterium called Cutibacterium acne, or the formerly Propionibacterium acne. So these two are the vaginal flora. So if you grow them in the urinary tract infection, you have to suspect a contamination rather than an actual urinary tract infection. But mind you, lactobacillus sometimes can cause urinary tract infection per se. So when you have a isolated lactobacillus growth in the culture and the patient is having a pyuria and symptoms, you can't just disregard lactobacillus, so you have to treat it as a cause of UTI. Right? So I stated earlier regarding the colony counts. So in a catheterized sample, you can diagnose urinary tract infection with a CFU more than 10 to the power 3. But especially in pregnancy, you can have low colony count. So in pregnancy, you diagnose the urinary tract infection even if the midstream sample is having more than about 10 to the power 3 colony count. You can diagnose urinary tract infection, especially in the context of symptomatic UTI, right? And so that you need to keep in the mind. So how do we treat this? So the reasons behind we discussed already. So how do we treat asymptomatic bacteriuria? So in a patient with asymptomatic bacteria, how do they present to us? So probably they might undergo a urine full report for a non-specific abdominal pain. That's the commonest situation. And you will get a pyuria. Then automatically you ask from the patient whether you have dysuria. No, nothing, I don't have anything. But you tend to do a culture whenever you have a pyuria, right? So usually people with asymptomatic bacteria come to you with a culture, isn't it? Because they don't have symptoms. So you will have the culture. So if the patient is having pyuria, you can treat according to the culture, right? So common antibiotics we use in pregnancy either to treat UTIs or asymptomatic bacteriuria are the beta-lactams, either penicillins like amoxicillin or co-amoxiclav, or the cephalosporins, oral cephalosporins like cefalexin or the cefuroxime or cefixime. So these two classes of antibiotics are commonly used because the relative lack of toxicity towards the fetus, right? Nitrofurantoin is also considered as an option. But there is a bit of a discussion about nitrofurantoin, whether it is recommended during the first trimester. There is mixed evidence, but some time back nitrofurantoin was avoided during first trimester. But if there are no other options, you can consider nitrofurantoin. It is being recommended by the American College of Obstetricians and Gynaecologists to treat UTIs in the first trimester. There were rare cases of cardiac defects associated with nitrofurantoin, but which is kind of very rare, and in the reasonable context you can use it, but try to use a penicillin or a cephalosporin if the culture is sensitive. And duration of therapy 5 to 7 days, which is enough. But the problem is 30% of the asymptomatic bacteria they fail to eradicate with the antibiotic treatment. So what to do next? Are we going to treat it? Or this area is debatable. There are a lot of studies which are showing retreatment of asymptomatic bacteria is not going to confer any benefits. So ACOG guidelines states like a follow-up urine culture and the treatment of is recommended in the previous literature, but you need a bit of more data, and but it's not known whether it improves the treatment of the outcome, right? So how do we treat UTI? Not antibacterial. This is asymptomatic bacteria. Now it's UTI. So usually you need to start an empirical treatment because patient is symptomatic. Cefalexin or a Cormoxclav would be a empirical treatment we usually start, and then once the urine culture is available, you can treat accordingly. The problem of urinary tract infections in the pregnancies, you can get recurrent UTIs. So sometimes when the pregnant woman is getting 3 or more episodes of UTI, you need to give prophylaxis for the duration of the pregnancy, which is recommended. And again, you can select the prophylaxis according to the susceptibility of the last non-grown organism. Nitrofurantoin and cefalexin are the 2 common antibiotics we use. So how do we manage pyelonephritis? So that's the most serious type of UTI. About 20% of the people, pregnant women with pyelonephritis, they can develop septic shock and even go up to ARDS. So which is a very important factor. You need to treat early and keep this in the mind. Absence of pyuria doesn't indicate there is no pyelonephritis. If the patient is symptomatic and having a loin pain, you clinically think it as a pyelonephritis and start treatment. And even if there is no pyuria, you will see a culture growing an organism later on. So keep that in the mind. And imaging, the place for imaging is a bit debatable. You need not to have an ultrasound scan at the very beginning to treat pyelonephritis, but clinically suspect and treat it. But if the patient is failing to get well, say after 24 to 48 hours of antibiotics, you need an ultrasound scan to exclude obstruction of that kidney, maybe a stone causing obstruction, or else just to see whether the patient has developed any abscesses around the kidney. So antibiotics wise, pyelonephritis, the first choice is cephalosporin. Ceftriaxone is a good choice for mild to moderate disease. But if the patient is in septic shock, the recommended antibiotic is the piperacillin tazobactam or the meropenem, because it covers the ESBL. And you can give IV antibiotics up to 48 hours and then convert to oral if the patient is getting better, if the fever is settling. And the usual duration of antibiotics are the 7 to 10 days of and the problem of pyelonephritis, it can recur about in 60 to 8% of cases. So if pyelonephritis is getting recurred, you can consider giving a prophylactic antibiotic, but it is not really indicated after 1 episode of pyelonephritis, but only if the patient is having recurrent episodes. So this is my last slide. Just to talk about a little bit about sterile pyuria, again an important concept. So the commonest reason for sterile pyuria is partially treated UTI. So whenever a pregnant mother is complaining of a urinary tract infection, the primary care doctor will usually start a treatment, but you have to send a culture before that ideally, but you will get people treated and then coming to you and your culture will be negative. So but urinary tract infection has not fully settled, so your pyuria is still there. You consider this as a sterile pyuria, but actually it's a bacterial infection. You are partially treated. And also, even after treatment, for some time there will be pyuria left. So this is also very important to know, otherwise you will tend to treat more and more antibiotics because there is pyuria. But you can have pyuria even up to 1 to 2 weeks after treating a cystitis. So if the patient is asymptomatic and you know that patient had a symptomatic UTI, and now there is some pyuria which is asymptomatic, you need not to treat it again, but you need to just monitor the patient. But there are other commoner causes of sterile pyuria where your culture is actually negative, but you have a urinary tract infection, but that particular organism is not grown in the urinary culture. The commonest is chlamydia, which is a sexually transmitted disease. The treatment is doxycycline. You need to suspect that and get a collateral history and treat it accordingly. And also Trichomonas vaginalis, which is not a very uncommon organism in Sri Lanka, which is a parasitic infection which can cause UTI. Cultures are not growing that. You need to get a urethral discharge microscopy to see the Trichomonas vaginalis, right? So, and also genitourinary TB, which is an uncommon thing, but you need to suspect that in a patient with diabetes, but it is a very, very rare thing. And fungal UTIs, especially candida, is not an uncommon thing in pregnancy because vaginal candidiasis is a common occurrence in pregnancy. And so you can get ascending infection to the cystitis or even pyelonephritis due to the immunosuppressive status of the pregnancy and get fungal UTIs. So keep these things in the mind when you are dealing in a patient with pyuria where your urine culture is negative and where you have symptoms. But sterile pyuria, there is a set of people, you don't have symptoms, but you need to consider partially treated UTI or a previously treated UTI in those instances. Okay. So that brings to the end of my talk. Thank you very much for listening.